My case study is on a 56-year-old male who presented to the emergency department of a rural hospital in Nebraska, and he had complaints of high fevers, severe dry cough, shortness of breath, and he had lost his sense of taste and smell. He had stated that he was running out of breath easily. He tested positive for COVID-19 on 9/12/2020. He was then given dexamethasone, which is a corticosteroid used for its anti-inflammatory and immunosuppressant effects, and it has been found to work on critically ill COVID patients. At that hospital, he had a chest X-ray, and it had found to have the chest X-ray had bibasilar infiltrates. He was then placed on supplemental oxygen of 6 liters, and then he was transferred here. He was a full code. His chief complaint was COVID-19, and his admitting diagnosis was pneumonia due to the COVID-19. He was admitted on 9/12/2020. He was a farmer. He never smoked. He had no HOMO2. His home medications were Tylenol and Levemir, which is the insulin. His current diseases are type 2 diabetes mellitus, obesity, acute hypoxic respiratory failure secondary to the COVID-19 pneumonia, a fatty liver, decreased glomerular filtration rate. He had hypertension and peripheral neuropathy. He had quite a few problems that actually had become apparent because of the COVID-19. He had leukopenia, lymphopenia, and mild thrombocytopenia. Some of his labs were an elevated BUN, which it means kidney injury or disease present. It was 28, and that was caused by his not very well controlled diabetes. It could be from his hypertension, and it could be from his COVID. All of them together just probably made it worse. He had an elevated D-dimer of 698. His white blood cell count was 11.57. His hemoglobin was low and 9.7. His hematocrit was low at 29. His glucose was at 213. When he was transferred here, he had got remdesivir, dexamethasone, and convalescent plasma, all for his COVID-19. He had been diagnosed with bilateral DVTs, which are clots in both of his legs, and he had a chest X-ray, and it was positive for extensive bilateral pulmonary emboli, and that he was diagnosed with that on 9/18/2020. He was started on Xarelto, which is a blood thinner, and it's used to reduce the risk of stroke and blood clots. And after the full dose of Xarelto, he had another CT done, and it was found that he had a new right upper lobe pulmonary emboli, even after the full dose. And he had developed acute diastolic heart failure and had paroxysmal AFib and aflutter. He started on Lasix for edema and Lovenox to help prevent another DVT. He had begun to develop increased oxygen needs and would go back and forth on the Airvo during the day and the BiPAP at night, like 100% FiO2. He was still experiencing issues with oxygenation and would sometimes even have desaturations into the 70s. Pulmonary had started to discuss going the route of like a lung transplant with him, but UNMC had rejected him because he had a high BMI, and when he was intubated, he had needs for high levels of PEEP. And on his chest X-ray, the results from the MD in impression and interpretation. This is from a chest X-ray on 10/8/2020. He had continued presence of bilateral diffuse, predominantly interstitial infiltrates, consistent with known clinical history of COVID pneumonia. He had diffuse ground glass interstitial infiltrates and had continued low lung volumes. He had developed ARDS, and that can be confirmed by the ground glass on his chest X-ray. He had reached his 20 days of COVID isolation, and he came out and he was finally able to come out of isolation, and he continued to have slow and steady progress, but he still continued to have high need for high amounts of oxygen. He was then intubated on 10/27/2020 because of his continued high oxygen needs. He tolerated his mechanical ventilation well, and family and the patient all discussed with the doctors, and they chose to go ahead and proceed with a tracheostomy because of his prolonged phase of ARDS because of the COVID-19. So then the tracheostomy was placed on 10/29/2020, and he underwent a bronchoscopy during the tracheostomy placement, and his cultures had shown gram-positive bacilli on gram stain. And after his tracheostomy was placed, he was experiencing some increased oxygen needs with that too. So when I saw him, his ventilator settings, he had a tracheostomy in place when I saw him, and he was in pressure control. He had a pressure control of 14 to get a tidal volume of 500. He was at a rate of 20, a PEEP of 14, and 80%. He was a very pleasant, very nice man. And when I walked in the room, or when anyone did, he would try his best to talk and communicate. But every time he would try to talk, his SpO2 would drop and fall into the 80s, and he would have increased oxygen needs. And he would have increased work of breathing. And he was encouraged to try to write more instead of trying to talk, because every time he talked, he would drop down in his SpO2. His respiratory medications were Duoneb 4 times a day, which is a bronchodilator that relaxes the muscles and will help increase airflow into his lungs. He was also on Brovana BID, and that's a long-acting beta agonist, and that will also relax the muscles and prevent bronchoconstriction. And he was on Pulmicort BID, which is a corticosteroid, which reduces the inflammation and swelling of the airways. His breath sounds were coarse and rhonchi, and would occasionally have a wheeze. So some connections. He had problems with pulmonary emboli in DVTs, and I know it's hard to connect things with COVID because not all the research and everything has been done about that, but there is some research about COVID-19 that it causes more clotting, and there's studies that explain like the COVID-19 triggers the production of antibodies circulating in the blood, and it causes clots in people hospitalized with COVID-19. So like the antibodies attack the cells, and then that triggers clots in like the arteries, veins, and vessels. Also, from the COVID-19, it had been found on one of his CT scans that he had like air-filled, thinly walled cysts and on like the lining of his lungs, and it's from the necrotizing lung because of his COVID infection. And so they were like pretty big, and the doctor said that if he had too much pressure in his lungs, or if he could even cough way too hard, one of those could pop and he could have a very large pneumothorax because the air would get into his lungs. Also, because of his comorbidities, like his not very well controlled diabetes and his obesity and his hypertension, he had a more severe outcome with COVID. He's more likely to have serious complications when infected because of these comorbidities. Because they have, with obesity, they have lower cardiopulmonary fitness, and they cannot move as well due to their poor lung function. Also with diabetes, like any virus, including COVID, their bodies don't process glucose as well during their illness, and their immune response can be weaker. And with his type 2 diabetes, they like live in like a chronic inflammatory state, which is setting them up for a more severe inflammatory response to COVID, which could do more harm than good. And so continuing on with his story, On 11/14/2020, a code blue was called on him because he was found to have his tracheostomy tube in his hand, which he had apparently grabbed himself and decannulated himself. And the nurse was found him like that because he was having decreased SpO2. And the patient had become more hypoxic, and his heart rate was 12, and his SpO2 was 14. An RT came to the bedside and was able to recannulate the patient. He then had immediate improvement of heart rate, blood pressure, and SpO2. Before, the patient had been kind of lethargic, and after, the patient was not responding to verbal commands, but he had a heart rate of 75, a blood pressure of 142/57, and an SpO2 back up to 94%. He had ongoing declines after this, and his SpO2 saturation stayed between 70 and 80% the next day, even on 100% O2. He was still on the ventilator. His wife had come in and they had discussed with her about like his prognosis, and they discussed with the patient too as well about like just what he wanted to do going on. He did not wish to go do not resuscitate at the time. He did not wish to go comfort cares or to be removed off the ventilator, but he did want increased sedation and pain medication. So his children came in, and his wife and him, they all discussed, and they all finally decided that he would go do not resuscitate. And so they kind of just went on to like the goal of then trying to just like alleviate some of his dyspnea and discomfort. And he had continued to decline throughout the day and was not improving. And he was noted to have ongoing hypoxia and had arrhythmias, and then he went into pulseless electrical activity, PEA. And he was still on the ventilator at this time, and his wife and his kids were there. And so after discussing with his family, they decided to discontinue the ventilator. And then after discontinuing the ventilator, he had a few agonal respirations, and then he passed away on 11/15/2020. So yeah, that is my case study.